Hello, everyone. Thank you to the organizers for inviting me. The goal of my talk is to highlight the positive role of DBS in dystonia and draw your attention to some of the gaps and limitations and the potential strategies that could be implemented to address these limitations. Here are my disclosures. Dystonia patients can no doubt benefit from DBS therapy. The experience is 30 years old. It started with few case reports that prompted design for large or moderate-sized randomized controlled trials. When the FDA recognized the clinical impact, DBS was approved under a special category, humanitarian use device. This is a market approval pathway for medical devices needed to help people with rare diseases. However, new epidemiological data from service-based record linkage studies and population-based studies shows that the prevalence estimate seems to be higher than what was previously estimated, which is more than 50 per 100,000 population. Could be affected with adult onset dystonia. If this is true, then that would not be consistent with the diagnosis of a rare disease. As you can see, a rare disease is something that affects less than 50 in 100,000. And if adult onset dystonia is not rare, then could we expect regulatory changes for DBS approval in future, especially for adult onset dystonia? There are many studies that have shown motor benefits with DBS in generalized dystonia. Here are two pivotal randomized controlled trials that showed benefits in the range of 50 to 60%. And in these trials, they followed their patients and they found that the benefits persisted at 3 and 5 years follow-up. Positive outcomes were also reported for focal cervical dystonia. In this RCT, which involved 62 patients, the patients were followed for 3 months. And what they found is that there was a 26% reduction in the severity score. Another important point that should be noted is that they found that there was a 5-point drop, but the standard deviation was also around 5 points, meaning that there was a wide range of improvement. Similarly, Twister's total scores, 6.7-point drop with a 7-point standard deviation. In addition to globus pallidus, subthalamic nucleus has also been tried for treating patients with cervical dystonia. In this study involving 20 patients, the improvements were in the range of 60 to 70%. In this recent systematic review and meta-analysis, motor outcomes were analyzed for isolated dystonia. 500 plus patients were included. Mean improvements were found to be more than 50%. Mean follow-up was 2 to 3 years. They found that higher motor and disability scores before the surgery or younger age at the time of surgery better were the outcomes. Then do we have sufficient data for all forms of isolated dystonia? For example, blepharospasm, MAGE, laryngeal, limb, task-specific dystonia. These are questions that remain to be answered. Tremor presenting in patients with dystonia can also be treated with DBS. At our center, we found that VIM was an effective target, as shown in this study. Although the tremor could be effectively controlled, what we found is that the concurrent or ongoing dystonia symptoms continue to remain bothersome. Does this mean that in such situations, both GPI and VIM would be needed for improvement in outcomes? That's another question that needs to be answered. Let's look at DBS and cerebral palsy. In this carefully selected cohort of 13 adults with dystonia chorioathetosis, the investigators were careful to have patients who did not have abnormalities, major abnormalities on the basal ganglia, in the basal ganglia. They also employed blinded video assessment. They found that the dystonia movement score improved by 25%. There were also improvements in the functional disability, pain, mental health related quality of life. On the other side, there was another study that involved children and not adults. Age was 7 to 18 years. Again, they made sure that the motor thalamus was intact on the MRI. In this study, the quality of life improvement was the primary outcome, and that did not reveal significant improvement at 1 year follow-up. How about DBS and tardive dystonia? Multiple studies have been performed. Some employed blinded assessments. Some were able to examine the long-term outcomes, but most studies involved small cohorts. So it is hard to draw firm conclusions. Scales used for assessment were also not designed for tardive dystonia. Could DBS improve quality of life? And the answer is yes. At our center, when we looked at a cohort of 16 patients, we found that the motor improvements persisted beyond 9 years, and the quality of life correlated with the motor outcomes. Short-term improvements were predicting the long-term improvements, meaning thereby those who showed improvements right from the beginning, they continued to demonstrate improvements even at long-term follow-up. And those who did not seem to respond well continued to remain poor even at long-term follow-up. Benefits have been found to be greater for physical quality of life compared with mental and psychological quality of life. How about non-motor outcomes? In this systematic review, 52 study data was studied and was evaluated. And what they found is that GPI DBS reduces pain related to dystonia. No major effects were found for anxiety, mood, and cognition. What can we tell our patients? Well, before they go for surgery, we could say that 25% could be excellent responders. 25% are likely not to respond at all. And the majority, 50%, are going to be in the middle, demonstrating mild to moderate response. As far as the numbers are concerned, it may be reasonable to say that the severity would improve by 20 to 30%, disability 40 to 60%, pain 40 to 60%, quality of life 40 to 60%, and mental would be slightly lower. Pain in the mental, the main improvements, pain improvements could be expected. Sleep may improve with DBS. And at this point, there is insufficient data on anxiety, depression, and cognition. The questions that remain are, why are outcomes so variable? Why some patients are non-responders? Could we predict non-responders or super responders? How confident are we about DBS for treating tardive dystonia and dystonia in cerebral palsy? Are the clinical scales used for outcome assessment adequate? Speaking of clinical rating scales, in this study that was conducted more than 10 years ago, a group of experts reviewed the scales used for assessment of dystonia. They reviewed scales available at that time, and there were also not many DBS studies at that time. The scales were examined for multiple criteria, including the clinimetric properties such as validity, reliability, and sensitivity to change. What they found is that only a few scales could meet all these criteria. Many of the scales that are available were not even eligible to be recommended further. Many advancements in the recent times are related to imaging and physiology. Probabilistic mapping has helped us in identifying the sweet spot. A sweet spot is not a spot, but represents a volume of tissue. containing axons, fibers, fiber pathways, and fiber tracts. When stimulated, they are relevant for benefits. So probabilistic mapping is able to identify where in the GPI or where in the STN or where in the VIM one could expect the best benefits. Along with sweet spot, we now know that there is also a hot spot in the GPI. Local field potential recordings with the help of DBS electrode has revealed that excessive pallidal synchronization has a peak at the theta band, 3 to 8 hertz, which might be responsible for generating dystonia symptoms. New DBS systems also have the capability to record the local field potentials while patient is at home, and this could be leveraged for better management of symptoms. The question that remains is, could we develop robust biomarkers that predict outcomes before the surgery? Some studies have looked at the impact of genetic etiology on the DBS outcome. In this systematic review and meta-analysis, when they pooled data for multiple genetic etiologies, they found that DYT-TORV1A did show a good motor improvement. Short-term was 40%, long-term was 60%. They then compared the outcomes of other genetic etiologies with TORV1A, and they found that some genes such as TOR, TAF, myoclonus dystonia, and KMT2B tended to have better outcomes, whereas TAP, PANC, and ADC Wi-Fi did not seem to lead to good outcomes. Similar kind of analysis was also done by another group. Then could we really gain insights into the unique attributes of these various forms of genetic dystonia that has been found to impact the DBS outcome? Some challenges related to DBS programming are, programming settings are usually determined with trial and error approach. Immediate clinical feedback for programming setting is lacking. Frequent battery replacements are needed because dystonia patients often require higher settings. Lead migration is a real concern, especially when children undergo DBS. Then could recent technological advances provide solutions such as closed loop programming, automated programming, remote programming? Can this all lead to easier prediction and reduction of programming burden? Onset time for benefits in dystonia is also observed to be long, which could be frustrating for the patient and the programmer. As you can see here, when comparing to essential tremor, which is usually quickest to respond, Parkinson's disease, dystonia seems to respond quite late. It is the slowest, and the range of improvements can be seen anywhere from 3 to 18 months. Some people may be primary non-responders from the very beginning, which could be related to if they have fixed dystonia, which is hard to treat, or if the lead position is suboptimal and the programming parameters have not been properly selected. Some people may lose the benefits to DBS, which could be referred to as secondary worsening. Is this something similar to DBS loss of benefit, which has been attributed to tolerance, habituation, disease progression? This is something that needs further workup. There are a few studies which have looked into or have reported secondary worsening. In our assessment of a multi-country cohort for DYT-TORV1A dystonia undergoing DBS, we found that younger age at onset, faster disease progression, and cranial involvement was associated with secondary worsening. Is secondary worsening also seen in non-genetic forms of isolated dystonia? What is the natural history of dystonia after DBS? Could DBS alter the natural history of dystonia? Finally, let's look at some of the strategies that could be implemented to improve DBS care. we could apply a methodical process for selection of candidates to get the best possible outcome. Launch multi-center concerted efforts, especially for less studied forms of dystonia. And one could leverage the Dystonia Coalition network to lead these efforts. Develop DBS-sensitive tools for outcome assessment. Approaching dystonia as a network disorder, targeting multiple nodes could potentially improve outcomes. For example, tremor presenting in dystonia or other symptoms co-occurring with dystonia. And one should also not forget the role of other nodes in the network, such as the cerebellum. Employ novel programming techniques. Discover blood imaging physiological biomarkers for pre-op prediction of outcomes. Increase epidemiological evidence on the incidence and prevalence rates. Engaging patient advocacy groups for improving access and facilitating regulatory changes. With this, I would like to thank everyone again. Thank you for your attention.
Thank you, Aparna. That was a wonderful summary of a huge topic, focusing on what works and what we still need to work on to make it work better. Questions or comments for Aparna, please put them in the Q&A or question box if you have any. I am looking for them now. Here is a question from Rick Staub again. So is there recent information that stimulation 24 hours a day from DBS is not as effective as alternating stimulation?
So there's more data for other diseases such as essential tremor and Parkinson's disease, especially essential tremor, where we could ask our patients to turn off the DBS at night. The idea of using closed loop programming or intermittent stimulation is broadly related to reducing the adverse effects related to continuous stimulation, or maybe some to avoid the habituation or tolerance that one could come across, or even the energy consumption. By using the stimulation as and when needed, it could reduce the energy requirements and thus avoid the battery replacements. But now, of course, we have the rechargeable batteries. For dystonia, even though closed loop programming is now, many few studies have been added to the literature, but turning off the DBS at night is not still a practice that we advocate.
Great, thank you. I have a question as we're waiting for people to potentially type some questions in. It's been a long time interest of mine, has been genetics, and my impression that for many, many years that some subtypes do really well and some don't. And now there are some fairly good large scale reviews of the topic, going back into the literature and saying which ones respond, which ones don't, and how well do they respond. And I think now there's pretty compelling evidence that genetic testing, at least for dystonia, is very reasonable before going to DBS surgery, so that you can inform the patient if they have a subtype that's going to respond well or not. My understanding, though, is this is not a norm even in the US. There are multiple variations of behavior, some groups thinking genetics is a waste of time and money, others thinking it's essential. And I guess, how do we get how do we wrap our brains and arms around that question? I mean, it looks like it would fit into one of your categories where you said we need multi-center studies, especially for the rarest subtypes, to collect data methodically, because what's happening now is when it doesn't work, people tend not to report it.
That's absolutely true. And I totally agree with you that one should definitely get a more insightful understanding of the patient and not really think that this patient has an idiopathic dystonia. And now, fortunately, some of even the commercial genetic testing facilities are offering the testing at a lower rate, mostly for the dystonia panel. But I guess you are thinking even at a broader level and more deeper level of whole exome sequencing or whole genome sequencing, and we can definitely learn a lot. And it could not just be a single gene, it could even be a polygenic risk score that we could determine to see whether that has any impact on the DBS outcome. But I think that the genetic underpinnings definitely can play an important role for prediction of outcomes, for sure. And as you saw, even in the review paper that I presented, there were not many cases, a few hundreds, but we can definitely pool more data in this direction.
Yeah, I agree. And for some rarer subtypes, there were only a handful of cases. So makes it hard to know what to recommend. So here's another question for you, maybe a more difficult one. Marie Vidaye is asking, what is your hypothesis on the emergence of akinesia or gait disorders in some patients with dystonia who are treated with GPI stimulation?
Yeah, thank you, Marie, for the question. And yes, that is one problem related to GPI DBS. Maybe 10 to 20% or maybe even higher number could eventually develop this sort of hypokinetic movement disorder, Parkinsonism, freezing, speech problem related to GPI DBS. I don't think we really have many insightful understandings. There was this one study that I came across, and I think it was by Dr. Limousin, and it was related to what they found is that the neural elements that were activated and were leading to the hypokinetic disorders were located within the same region, which was identified as the sweet spot. We don't know whether the theta suppression, how it can have effects on the downstream networks, the thalamocortical networks, or even the other brainstem networks, or maybe even the cerebellar networks. We don't know how eventually all plays out, because how DBS works, that itself we don't have a clear understanding about. And so the hyperkinetic and hypokinetic both arising from the same location within the GPI is definitely very intriguing.
Great, thank you, Aparna. I think it's a tricky question to answer, but something we probably need to get an answer for sometime soon. I have another question for you. This one comes from Joel Perlmutter, and his question is, does the difference in response to specific types of mutations suggest different underlying network dysfunctions?
I think my personal answer is yes. We don't have a lot of data. As I said, that not all forms of dystonia have been adequately studied, especially for the DBS outcomes. But I think, and then for few genetic types, there is really just few case reports. But I think the answer is yes. It's a different network that is getting affected. And the heterogeneity of dystonia is one of the major limitation, and the variability of outcome. That's the other limitation.
Yeah, absolutely. I agree. I think we're going to find different networks. Not one network for every gene, but probably some genes cluster in one network and some genes cluster in another network. And knowing that in advance would be helpful for surgical interventions, knowing what to target. So still lots to learn there, I think. Now, there's another question in here. This one is from Norbert Brueggemann from Germany. And it is, do you think that STN-DBS or combined GPI-STN-DBS is an option for GPI non-responders?
So thank you, Norbert. At our center, we do consider the possibility, we call it the rescue lead. And we do have a small cohort of people that we have followed. A few years ago, I looked at our own data and I identified about 10 people out of 110. So roughly around 10% where we had to go for another lead, choosing another node in the network. So most people had already tried GPI DBS and we followed them, and then it was a secondary loss of benefits, or some of them had primary loss of benefit or primary non-responders. And we found that adding STN, or in some cases VIM, depending on the phenotype, led to improvements. So that is one possibility, and a rescue lead could be employed more frequently.
Great, thank you, Aparna. Let me take the opportunity to thank you again for stepping in to give this presentation. I think it was fabulous. I would also like to thank Cindy for the earlier presentation. I am not seeing any further questions. Oh, wait a minute, one just came in. Aparna, are you ready? What do you think are the next best steps in this? This one comes from Angela Hewitt. What do you think are the next best steps in establishing biomarkers that may help optimize DBS programming? And do you think monitoring multiple areas with stereo EEG leads, for example, GPI, VIM, STN, such as Terry Sanger's group is doing in kids, would be helpful?
Thank you for the question. And of course, I did not have, given the time constraints, I did not really cover all the novel approaches and all the new things that we are learning from all the physiological biomarkers recorded from the DBS electrode itself, or maybe from the motor cortex, the theta, the beta, the gamma, phase amplitude coupling. And I totally agree that we definitely can leverage, because the electrode is implanted right within the dystonia network. We can learn so much about the network and how it communicates with each other, the intra-regional, inter-regional, the direction of communication. There are so many things that we can learn, and stereo EEG can definitely be one option. And there are some EEG and local field potential recorded from the DBS electrode, those kind of studies that have been conducted, and they have provided some insights. So the answer is yes.
Perfect. Thanks again, Aparna. And thanks again to all of the speakers for the summary of current treatments that we have for dystonia, medical treatments involving oral therapies and botulinum toxins, but also surgical therapies. They're all great. Our patients need them. We all use them. But I think the common theme for all of them is we can do better. And there are lots of things we still need to make improvements on. So thanks again, Aparna and Cindy.